Today we are going to discuss about the topic iatrogenic factors. So basically we are going to discuss what are the different types of iatrogenic factors which helps to cause in periodontal diseases. So the definition of iatrogenic factors are the when inadequate dental procedures that contributes to deorientation of the periodontal tissue are referred as the iatrogenic factors. That means these iatrogenic factors, when we routinely perform the dental procedures, helps to contribute the periodontal tissue destructions are the iatrogenic factors. So there are different types of iatrogenic factors. First is the margins of the restoration. Basically, there are three types of restorations margins. First one is the overhanging restoration. Second one is the location of margins, and third one is the marginal roughness. So what is overhanging margins? What happens when there is a overhanging restorations is there, which causes the accumulation of food. So because of accumulation of food, there is a increasing chances of the periodontal diseases. So what happens when there is a overhanging margins that inhibit the patient's assets to remove the accumulation of the plaque. So there is a chances of ecological balance of the gingival surface into an area that favors the disease-associated organisms, which leads to the periodontal diseases. So because of the overhanging margins, there is an accumulation of food which causes the increase in bacterial growth resulted into the periodontal disease. So second factor is the location of the gingival margins. Basically, there are three types of the gingival margins. First margin is the subgingival margin. Second one is the epigingival margin, and third one is the supragingival margins. So when there is a subgingival margin is present, which results into the severe gingivitis and deep pockets. When epigingival margins of the restorations are there, then results into the less severe form of this gingivitis, and when supragingival margins are there, which normals as a natural tip. Next factor is the marginal roughness. So in marginal roughness includes the grooves and scratches. So when there is a grooves and scratches present, which causes the further food accumulation. So in grooves and scratches in the surface of fairly polished restoration, example porcelain restoration, gold restorations, which leads to the accumulation of plaque, causes the periodontal diseases. Second factor is the inadequate marginal fit of the restoration. Normally, subgingival margins typically shows a gap between 20 to 40 micrometer between the margin of the restoration and unprepared tooth surface, which results into the favors of the bacterial plaque colonization. So, moving towards the next factor. Next factor is the contour and open contacts. So, normally there are over contour counts are present and inadequate uh, contours are there. So in over contour crowns, the surfaces are buccal, lingual, occlusal contours as there. And second one is the inadequate interproximal hemorrhages. What happens when these buccal and lingual contours are over contour? It when there is a over contour is there, which prevents the self cleansing mechanism from the cheeks, lips, and tongue. And when the under contour crown is there, then does not have much destructive effect compared to the over contour restoration. Next one is the occlusion contours. What happens when occlusion contours? Normally, occlusion contours established by marginal regions and related developmental group. So normally they deflect the food away from the interdental spaces. So when there is an inappropriate occlusal contacts, then this causes food impaction and plaque retentions. What is normal food impaction? Normal food impaction is the forceful wedging of the food into the periodontium by the occlusal forces, and the cuts which causes the forceful wedging of the food into the interproximal areas are called as a plunger cut. So whenever there is a improper occlusal contacts is there, there is a food accumulation and plaque retentions which results into the further periodontal diseases. Next factor is the inadequate interdental hemorrhages. That means when there is a inadequate interproximal tissues is there, what happens whenever there is a inadequate hemorrhages are present, which results into the papillary inflammations of the gingiva, which results into the gingival diseases. Next factor is the restorative material. In restorative material, these restorative materials are not themselves injurious to the periodontal tissues. One exception to this may be self-curing acrylics. Retention capacity of the different restorative materials are different, but yet can be controlled if the restoration was well polished and was accessible to the oral hygiene measures. If the undersurface of the contact is fixed, ridges should be barely touch the mucosa. Access for the oral hygiene is inhibited with the excessive contact to the tissue contact. Next one is a design of the removable partial denture. So there is a different designs of the removable partial dentures. So mm, basically, removable partial dentures favors the accumulation of the plaque, results into the gingival inflammations, periodontal pocket formation, and mobility of the teeth, which results into the further periodontal diseases. Next factor is the restorative dentistry procedures. In restorative dental procedures, normally we use the different rubber dam, clamps, metal brands, burrs, which results into the laceration of the gingiva depending on the various degree of mechanical trauma, producing transient injury that generally undergo repairs. Forceful packing of the gingival retraction cord into the sulcus to prepare subgingival margins on the tooth or for the purpose of the obtaining an impression may causes the mechanical injury of the periodontium, which results into the impacted dentist in that area causes the periodontal infection because of the there is a foreign body reaction happens. Next one is a malocclusion of the tooth. Basically, what happens whenever there is a malocclusion or malalignment of the teeth is present, which results into the different plaque accumulation because patient is not able to maintain the plaque control. So what happened whenever there is a irregular alignment of the teeth results into the more plaque control. Severe author found a positive correlation between the crowding and periodontal disease, but others didn't find any correlation. When next factor is the occlusal disharmonies. Restoration that does not conform to the occlusal pattern of the dentition may cause the injury to the supporting periodontal tissue. This is called as a traumatic occlusion or trauma from occlusion. So what happened whenever there is a trauma from occlusions is there, there is a results into the periodontal diseases. So there are different histological features of the periodontium related to the trauma from occlusion. What happens whenever there is a trauma from occlusion occurs, which results into the widening of the periodontal space that results into the reduction in number of collagen fibers and increase in vascularity of the leukocyte infiltration and also increasing number of osteoclasts on the alveolar bone. That means trauma from occlusion is basically traumatic occlusion, that is the occlusal force causes the trauma to the periodontium. So whenever this trauma is results by the occlusal forces, what happened? There is a first sign is a widening of the periodontal space. So whenever there is a widening of the periodontal space, basically periodontium is composed of the different collagen fibers, osteoblasts, other different leukocyte infiltrations, and other different cells. So whenever these periodontium get widened, the number of collagens is reduced. So because of the reduction in collagen fibers, there is an increasing leukocyte infiltration, which results into the increase in osteoclastic activity. Osteoclast is activity of the alveolar bone. So next iatrogenic factors is the failure to replace the posterior tape after the extraction of the first case is the after the extraction of the mandibular first molar. So when if the first molar is extraction and there is a failure to replace that tooth, what happened? If the first molar is missing, then the second molar is mesially shifted to the adjacent tooth, and the premolar is distally shifted to the adjacent tooth. So what happened whenever after the extraction of mandibular first molar with failure to replace, the initial change is the mesial drifting and tilting to the mandibular second and third molar, as well as extrusion of the maxillary first molar. Then next is the if we fail to replace the posterior tooth. So as the mandibular second molar tips mesially and its distal cusp extrude, it acts as a plunger cusp. Plunger. So whenever the distal crest of the mandibular second molar wedge between the maxillary first molar and second molars and the open contact by deflating the maxillary second molar. Last is the periodontal complications associated with the orthodontic therapy. Basically, during the orthodontic therapy, there are two types of effect. First one is a direct effect, and second one is a indirect effect. So, what happens whenever there is a direct or indirect effect? Uh, In indirect effect, favors the plaque retention and food debris resulting to the periodontal disease. And indirect effect, there is a creating of the excessive unfavorable forces on the teeth and supporting structures uh, results into the excessive force, which causes whenever there is a excessive force results into the necrosis of the periodontium and alveolar bone, which results into the increase in the risk of apical root resorptions. Last one is the extraction of the impacted third molars. Extraction of the impacted third molars oftenly results into the creation of vertical defects distal to the second molars. However, this iatrogenic effect is unrelated to the flap design, but it is related to the presence of the plaque, bleeding on pudding, pathological widening focal, inclination of the third molar, and root resorptions of the second molar. It appears to occur more often when third molars are extracted in individual older than the 25 years. Last factor is the habits and self-inflicted injuries. So there are basically different types of injuries. First injury could be the toothbrushing trauma. So basically, when trauma results by the faulty toothbrushing, these are the two types of trauma. First one is acute, and second one is a chronic. Acute toothbrushing technique results into the erosion and diffuse erythema, ulcers, acute gingival abscess, which are uh, because of the faulty toothbrushing techniques. So the history of acute trauma could be the signs of acute gingival abrasions are frequently noted when patient first uses the new brushes, and chronic trauma from trauma by the toothbrush should be the signs of the chronic trauma are buccal and lingual recessions with attachment loss and severe abrasion. So whenever because of the traumatic toothbrushing technique, two types of the trauma occurs. First one is the acute and second one is a chronic. So how will I identify acute and chronic toothbrushing trauma? So in acute faulty toothbrush technique, there is a erosion and diffuse erythema is present. Also, ulcers are there, and acute gingival abscesses related to the specific tooths are there. And in chronic faulty toothbrushing techniques, there is a you can see patient is always having buccal and lingual recession and attachment loss and cervical abrasions. Second is the chemical injury. Chemical injury, basically allergic inflammatory sites. The gingival changes range from simple erythema to painful vesicle formation and ulceration. Example, because of different over use of the mouthwash, dentifrices, denture materials causes the chemical injury to the periodontal tissue, which acts as a iatrogenic factors of the periodontal diseases. Second is the non-specific injuries effect of the chemicals of the gingiva, in which examples of the non-specific are the topical application of the corrosive drugs such as aspirin, phenol, silver nitrate. So what happens whenever there is an application of the aspirin, phenol and silver nitrate, this results into the non-specific injury to the periodontal supportive tissue and acts as a iatrogenic factors. Last one is a tobacco use. So the frequency of the tobacco use is the results into the oral leukoplakia, increased incidence of the gingival recession. Third one is a results into the cervical root abrasion, and last one is a root caries and high incidence of the severe periodontal diseases. So basically, you have to uh, reminder that there are different iatrogenic factors. Basically, what are these iatrogenic factors? These factors are contribute to the these basically these factors are the in faulty dental procedures or inadequate dental procedures that contributes to the formation of the periodontal diseases. So basically there are just remember according to the department. First, in orthodontic department there are various procedures can be done like orthodontic therapy. So what happens whenever there is a orthodontic therapy? Orthodontic therapy results into the direct and indirect effect which causes the accumulation of the food, and patient is unable to clean their mouth or unable to maintain their oral hygiene, so which causes the results into the plaque accumulation and results into the periodontal diseases. So first one is the orthodontic department. So moving towards the second department is the prosthodontic department. So what happens in prosthodontics? There are different restorations can be done or removal partial dentures can be done. So what happened during the restoration? Basically, whenever uh, there is a restoration, there are different margins of the restoration: epigingival margins, subgingival margins, or supragingival margins. So what happened if these margins are not properly placed to the tooth? So inadequate or faulty margins of the restorations results into the plaque retention to the interproximal spaces, which results into the inability of the patient to remove the plaque or plaque accumulation in that area, results into the further periodontal diseases. Second one is a whenever there is a open contact is there, results into the periodontal diseases. Next is the endodontic treatment. So in endodontic treatment, normally there is a we use rubber dam, burrs, then different materials. So what happened? The during the when we use the rubber dam or different burrs, this results into the injury to the gingival tissue. This results into the laceration of the gingival tissue, causes the different types of the gingival materials. So moving towards the occlusal surface, whenever there is occlusal surface, there are different grooves and scratches. So because of these grooves and scratches, there is a chances of the accumulation of the food in that grooves and scratches. So what happened? These increases the bacterial growth in that area, resisting to the periodontal tissue. So next one is a contour. Whenever there is a over contour or under contour surfaces is there. So when the over contour is there, there is a because of over contour restoration, patient is not able to cleanse properly by the different mechanism like cheeks, lips, and tongue results into the periodontal tissues. Next is the restorative material. There are different various quantities in the fixed beaches or restoration or replacement. So these causes the excessive tissue trauma to the underlying surface of the gingiva, results into the trauma. So basically there are different types of designs of the removable partial dentures. So whenever there is a removable partial dentures, there is can these removable partial favors the plaque accumulation, results into the gingival inflammation, periodontal pockets, and mobility of the teeth. And in malocclusion, whenever there is a malocclusion, if there is a accumulation of the plaque, results into the failure, results into the periodontal tissue. And if we replace or fail to replace the missing tooth or extracted teeth, there is always drifting of the adjacent teeth or opponent tooth, results into the periodontal